Welcome, everyone, and thank you so much for being here with us today, part of this really timely community conversation on practicing harm reduction during COVID-19. I would like to acknowledge the land that we are on. I live and work on Treaty 6 territory in the homeland of the Métis, and we acknowledge Saskatchewan as the traditional territory of First Nations and Métis people, which includes Treaties 2, 4, 5, 6, 8, and 10. We pay our respect to the First Nations and Métis ancestors of this place, and we reaffirm our relationship with one another. And we recognize the legacies of colonialism and systemic racism in Saskatchewan, and the focus and sustained efforts as we confront historical and contemporary injustices and work together for a vision for health equity for all. My name is Erin Wolfson. I'm the Community Engagement Specialist with the College of Medicine in the Division of Social Accountability at the University of Saskatchewan. And this webinar is part of a series of online community conversations hosted by the Division of Social Accountability, where we hope to take a deeper look at pressing and emerging health equity issues facing our communities. Each conversation brings together local thought leaders and experts, researchers and practitioners to share knowledge, perspectives, and frontline experiences. In Saskatoon, through the Saskatoon Interagency Response to COVID-19, agencies have come together across systems and sectors to raise questions and coordinate actions while centering the needs and lived experiences of people living in vulnerable circumstances. And through this series, we hope to profile this incredible collaboration, and our conversation today, as well as our conversation around food security next week, will feature some of the people and agencies involved in that effort. The COVID-19 crisis has amplified deep inequities in our society, but it has also provided us with opportunities to sow the seeds for long-term transformative change. So we hope through these conversations to discuss concrete actions to meet the needs and support populations who are disproportionately affected by the crisis, while at the same time, hopefully beginning to explore what COVID-19 is teaching us that might help us to advance towards a vision where health equity is a reality. So before I introduce our featured guests and host for this conversation, I'd just like to quickly introduce my two colleagues from the DSA who are helping to keep this conversation running smoothly, Joanna Winachek and Carla Seguin. So Joanna is here, you can't see her, but she's here behind the scenes helping to make this all run smoothly. And so thank you so much for all of your work, Joanna, on that. And Carlin will be helping to moderate the chat, watching for comments and questions and some key themes. So I'll actually hand it over to Carlin to talk a little bit about what that looked like.
Hi all, thank you for being here today. We're going to have a really large group, so that's great. Just in a quick discussion with the two presenters, the two guests we have today, they would really like to hear from you in terms of what you want to learn out of this and what kind of conversations you want to have. So do keep the comments coming. I'll do my best to help moderate and potentially draw some themes together to help direct that conversation. But if you do have things that you'd like to say, put them in the chat or put them in the Q and answer. I'll be moderating both. And our lovely guests will have an opportunity to respond as well. So please keep that up, and yeah, looking forward to this conversation.
Yeah, and thanks everybody again for being here with us. This really is a timely and critical conversation around harm reduction during COVID-19. So to lead us into this conversation, I'm so pleased to welcome with us today, Kayla DeMong and Barb Fornssler. Kayla is the Associate Executive Director and Family Support Coordinator at AIDS Saskatoon. Kayla has been working for the past 13 years providing support to children, youth, and families in Saskatoon. She sits on the boards of Quint Saskatoon, Station 20 West, and CUSER. As part of the Saskatoon Interagency Response to COVID, Kayla has been working as the Sheltering Branch Director, helping operationalize supports for Saskatoon's homeless and vulnerable populations. Thank you so much for being here with us today, Kayla.
Thank you.
And Barb is an adjunct faculty member in the School of Public Health and is in the Knowledge Translation and Exchange Coordinator for the Canadian Research Initiative in Substance Misuse, Prairie Node. If I said that correctly. Dr. Fornssler has been working in substance use research since 2011 and teaches the course Studies in Addictions yearly for both the School of Public Health and Department of Sociology. Most importantly, when she's not in the classroom, Barb enjoys camping adventures alongside her partner and their dog, a 3-year-old Great Dane named Opal. Thank you as well, Barb, for being here with us. And thank you all for joining us today and being part of this important conversation. And I will pass it over to Barb to get us started.
Excellent. Well, thank you so much first to everyone attending and to the Division of Social Accountability for hosting this timely and important conversation. It's wonderful to be here today and having a look at all the wonderful people who've joined us online, some familiar names. Hello to everyone, and some real expertise joining here as well. So I think it's going to be a great conversation. To basically start us off today, I thought, offering some kind of definition or an operative definition of harm reduction might be helpful. And so really what we're trying to address with harm reduction is policies, programs, and practices that aim to minimize the negative health, social, and legal impacts of substance use. So that's one working definition. And mostly, we received a lot of really great questions in advance of this webinar, and are hoping to try and engage this as conversationally as possible. And I don't know if Kayla, if you want to jump in here, I feel like you've got much more expertise on the front line on the concrete practices of harm reduction, and I'm happy to jump in with evidence as we go.
Yeah. So welcome everybody, and thank you so much for taking the time out of your day to sit and listen to us for a while. And I, like Barb was saying, I'm really hoping we can try and make this as much of a conversation as possible, being that we can't actually see any of you or hear any of your voices and have that interaction. But I'm really looking forward to this conversation, and the questions that we were sent in already are really good, and really looking at asking about how we can apply harm reduction in frontline services and programs and practices. From my perspective of harm reduction and where I come from, at Aid Saskatoon, we really take that definition of harm reduction and go beyond specifically substance use. And a lot of harm reduction programs and practices are really centered around substance use. But we have programs throughout our building that take that core fundamental principles of harm reduction and have applied them to different populations who normally we don't associate with harm reduction. So we have a family support program, and that's what I usually do in my non-COVID life is run that program that works with families who are at high risk of apprehension. And so how do we take the principles of harm reduction and apply them to the child welfare and child protection system? And so as we're having these conversations, I really hope that everybody can take a step back and broaden their understanding of harm reduction and move outside of, the idea that harm reduction is just needle exchanges or safe injection sites, right? It really is an integral part of how agencies should be building their policies and their practices and designing their programs and training their staff. And so, as we go forward into this conversation, please keep that in mind. One of the things I just want to start off by talking about is some of the function of what we've been doing with the Saskatoon interagency response, because that is really been a key player in how we've been able to respond to COVID in our communities. And there's some people on this call that sit on that group as well, and I'm really glad they could join today. I think yesterday I was told 70 days now that we've been entered into this response, and it became really clear really early, like the first day that COVID hit Saskatchewan, that initiatives centered around specifically homeless populations and highly vulnerable populations weren't going to be looked at by our government and our public health agencies. All the messaging coming out and all the information coming out was really targeted to the general public, which of course it has to be. But it became really clear really quickly that there wasn't going to be this response to the people that were going to have some of the biggest barriers in working through this pandemic. And we've talked a lot about right off the beginning, how do you self-isolate if you have no home? How do you wash your hands if you have no sink? How do you practice proper hygiene if you have no bathroom to access? Like all of these things, right? And so the Saskatoon Interagency Partnership picked up really, really quickly this response. I believe there's over 50 people or 50 agencies and groups represented on that in that body, and 36 staff that have been operationalized to address specific things around vulnerable populations. And so we have, initiatives around housing specific things. So, a hotel for people to self-isolate in, housing for people who are homeless that I will get into a little bit later. And, initiatives within shelters. We have groups looking at children and families and youth and elder and senior populations, things focused around specific health initiatives like our core testing site and harm reduction and overdose specific responses and those type of things. So the work that the interagency response has been able to do in the last 70 days has been unbelievably remarkable to see. And I've only been in this field for a little over a decade, but I've never seen anything happen in the way that it has happened in the last 70 days. And the partnerships that we've been able to come up with and the programs and the way funding is flowing and the way everybody's working together and that collaboration is really unprecedented. And, although there is still significant gaps in what is being offered for people who are affected by substance use and people who are homeless and who are vulnerable and don't have the financial resources that some other people do. There's like huge gaps in addressing the needs of those people. We have been able to still make huge strides and work through some things that without this collaborative, I don't think would have been worked through. Do you have anything to fill in there, Barb?
Oh, no, the phenomenal effort. I think it really reflects on, I often say sort of, prior to COVID's arrival, that many health providers and frontline workers are succeeding despite the system and not because of it, and reshaping some of our systems and pathways to care in order so that you're not having to work against, in a sense, the system, but the system supporting the initiatives and the efforts that you're making is an absolutely fundamental change that we need to see. And as you were saying, it's sort of the interesting aspect of COVID for me and sort of watching and seeing the good work going on is how it pressurized an already at capacity system. And there was a lot of concern around that. And so how we reduce that sort of systemic burden is important. And really, we hear the phrase, meet people where they're at, constantly. And then we're often asking folks to do acrobatics to meet the system's needs rather than the system changing to meet theirs, right? So no, I 100% agree. And it is an unprecedented effort. And it's phenomenal what's been delivered. And I was thinking about some of the questions that we were provided beforehand, and one of them was sort of around kindergarten to grade 12 education initiatives and sort of what teachers can be doing, what classrooms can be doing, and sort of how educators and their students can be engaging equity in their classrooms. And I thought that was a really wonderful question because it brings home, to me anyway, the influence, the important aspect of addressing stigma on health to understand how stigma is impacting health outcomes and access to care primarily. And so if we can start learning about stigma at a younger age and how to prevent that judgment that often comes when we see health inequity without sort of a background or an understanding of where folks are at and where they're coming from, a lot of times I think that leads to judgment and judgmental language and so on and so forth. So for that question, I was just thinking about, if we started talking about stigma, what stigma means and how it's impacting health services, along with everything else, at a much earlier age, that would hopefully provide some opportunity for folks to rethink things a little bit. There is a great resource, Dr. Teresa Tam, the Public Health Agency of Canada, their report for 2019 was all about stigma and the impacts of stigma. And so that's a great resource I think folks could look at. The other question we had that sort of connects to this education question as well is looking at programs. How do you reach youth? How do you sort of further? How do you build resiliency? I think is a root of that question in many ways with youth, and a lot of times what the scholarly literature says anyway, and what I've seen, myself and in working with community over a number of years is, when it's by youth for youth and youth driven and youth led, and those voices are respected and put at the forefront, the messaging is heard in a different way than when an adult is sitting there sort of finger wagging about appropriate behaviors, right? And we've seen this sort of across, whether it's substance use programming or other programs. If we can have that sort of by youth for youth approach, so that they're involved from the ground up in the programming design and delivery, that's really important, and we see more successes through that. One example might be the Youth Action for Prevention program in the Sask Prevention Institute, and I know that's maybe not everybody's first vision of what harm reduction might look like, but when people have information and honest information that goes beyond the just say no sort of paradigm, they're able to assess risk and these things, and they're able to put protective factors in place and basically make more informed decisions. COVID-19 has sort of thrown our entire society into a time of harm reduction thinking, in a sense, on a broader scale. And I think that's a really important thing to acknowledge in this. We're all being asked now to assess our risk of public engagement and how we're going to mitigate those risks, whether that's masks, hand washing, hand sanitizer, physical distancing, and that sort of thing. That's very much a harm reduction kind of approach to maintaining vital social connections in a time when we need to be physically distant. So.
Yeah, I've never seen so much harm reduction initiatives in action at one time, right? Like we're living harm reduction now. Every decision we make, everything we do is all based in that harm reduction principle of, reducing risk to health. And so wearing masks, social distancing, the way we shop, the way we're operating in our world is now really taken on that health lens of harm reduction. And in looking at, a bit to build on what you were saying about the education system, we don't educate people in a way that trains them or forms them to be non-judgmental and non-discriminatory. We approach education from a very privileged point of view, and talking about stigma, talking about discrimination in a way that really highlights that it still exists. We often talk about discrimination as past things and don't often acknowledge what is happening currently in our systems. And, as a parent of kids that are going through the K-12 system currently, like the conversations aren't happening around, they know some people are poor, but why are they poor, right? We don't talk about those structures. We don't talk about why people are homeless or the barriers that they're facing in education. And I think that's a really important shift that our education system has to make, is we have to stop talking about these things as if they have previously happened. And it has to be acknowledged that the things that have been put in place by our health system, our social welfare system, our child protection system, our health systems, all of those things are often the root of many of that discriminatory practice. And so when we look at education for children, talking about stigma and what it means to have those judgments, talking about substance use disorder in a different way, and substance use, it can't just be a good and a bad thing. It can't just be a do or a don't thing. And if you do it, then your life is, coming to an end, right? And changing the language around how we talk about substances and sexual health and all of those things is so important. And I really believe that from a young age, our education system could have the capacity to teach children what informed choice looks like. And informed decision-making in education is so important in harm reduction, because you're really looking at weighing all the factors that you're experiencing. There was a question that popped up in the chat box here from Carlin, just around the impact of the closures of schools on vulnerable families. That's been tremendous. So our family support team worked with over 800 vulnerable families last year. And so trying to maintain contact with those families while they're in this pressure cooker of, health inequity, poverty, food insecurity, and now have their children home all of the time, has really amplified how important it is to have community supports accessible no matter what. And many of our families relied on school-driven food programs to feed their children all day. And there's been a lot of work done by both the public and Catholic school division to still distribute food to families who are accessing those programs. The access to enough food is always an issue in our community. We have tens of thousands of people who rely on our food bank every month to feed their families. And so when you go from having to focus on feeding your children 1 meal a day to having to feed them 3 meals a day, that's huge. The mental health aspect of being stuck at home with your children all day. I know any parent that has had to deal with homeschooling and all of those things and has the resources to deal with those things is going crazy with their children. I know I am. And to then look at families who are already facing tremendous barriers and having factors in their life that did put their children at safety risk. So, we're seeing increases in issues around neglect, mental health, substance use, all of those factors that could potentially mean intervention from our Ministry of Social Services. As well as things that we often take for granted is access to technology for homeschooling, access to Wi-Fi. How do you reach out for help when you need help if you don't have a phone and nobody's coming to your house to check on you? And so all of these things have been huge implications for the families that are living in our community. We have a children and family group in the response structure. And one of the things that was identified, even women who are giving birth at the hospital, who are identified as vulnerable, whether it be for mental health or, poverty-related issues or anything like that, being sent home from the hospital with newborn babies without a way to contact any community supports. And because agencies are closed and because supports have closed down, nobody knows how to get help. And so you're stuck in these situations. The other thing that is being reported worldwide, and, to tie in the conversation that happened on this platform last week, is the interpersonal violence and the increase. And there's huge impact to children and family systems. One of the support programs for women has seen like a 20% increase in her caseload in the last, how many ever weeks of COVID. And people are trapped. They're trapped in these situations because all of the things that we have put into place prior to COVID that weren't already sufficiently available to families and to the community aren't available. And so how do we reach into those homes and gain access to safety plans and access to programs and resources when our system pre-COVID was already at capacity? And, during COVID, there is no capacity, right? So the implications are tremendous in family systems right now.
And I think to follow up on what you're saying there too, around how in some ways the system is just not able to respond appropriately in these circumstances too. And that's where I think the reliance on interpersonal networks, personal connections, ensuring that we're connecting with our friends and family and neighbors as much as we possibly can through whatever means possible, whether that's, waving across the street and sort of how's it going today, or, these simple sort of gestures of, hey, I see you, I'm connected, that we're connected in these ways is going to be, a thread to hold on to at this time in a way that it always is, in a sense that there was a TED Talk that was quite popular about a year ago that the opposite of addiction is not abstinence, but is connection. And really what we've seen in the COVID time era, if you want to call it that, is again a severing of lines of connection in a sense through these shutdowns and the impact of that disconnection that's happening. And so ensuring that, you know, a lot of the times I hear sort of, what can I do as an individual? And I'm like, that 5-second pause to wave to your neighbor, that moment to say, hey, you know, are you guys doing all right? My own upstairs neighbors, sort of making sure that they have access to groceries, things like that are just, you know, somebody needs a ride to a medical appointment, like whatever it is that we can do as individuals, we need to look around in a sense and sort of say, what can I do here? What is needed, and how might I help meet that need in some way? I often say in class, none of our systems are perfect, none of our approaches are perfect, but doing something is better than doing nothing. So do something to reach out, even a sign in your window that's like, hey, we love you, we're thinking of you, whoever it is that's out there, sort of thing. Seeing that signal of connection is vitally important at this time. And yeah, just sort of going back to some of those, you know, how from housing to interpersonal issues and so on. I mean, a lot of times in the health world, we talk about these as social determinants of health. And sometimes they're viewed a little too, they're a little too solid in a sense. Like we like to accept that social determinants are there, and then we just work around them. And the great thing about social determinants is that we can change those through systemic response, through shifting our policies, by addressing things on a broader level. Many of the social determinants don't have to be determinants of health. They are because of how our system is running, but we can change that. And I think that ability to change our approach has been also underscored during COVID. You know, what was needed? Well, billions of dollars in support funding, and they made it happen. So we can make it happen as a society when we choose to. These are choices that we're making on a daily basis collectively. And I think COVID's showing us that we can make different choices as we go forward.
Yeah. I think that ties really well into the next question that was here around, you know, what has happened with the collaboration through all of this. You know, it's no secret that systems tend to operate really siloed, and so do organizations, right? We tend to operate pretty independently of things, and we have a few partnerships here and there. But generally things are done really independently and away from, you know, what other agencies and programs are doing. What this collaboration has showed us is that if we can work together, things happen really quickly. They happen really efficiently for way less cost than it does normally, and that we can coordinate services and meet concerns that are coming up in, you know, a timely manner, right? And so as for an example, talking about overdoses. And so we've seen an increase in overdoses with COVID, and that's been reported right across the country. One of the problems that we have in Saskatchewan is we don't have, and in Saskatoon, we don't have up-to-date overdose stats being released. Right now, we have stats being put out by Medivy. That's kind of it. We have no publicly released stats from our health authority around what our overdose numbers do look like. Medivy puts out a little poster every week that shows how many overdoses they've responded to in that week. And in May, it was 262. And in March, it was 195. So we're seeing these increases. And one of the things that the harm reduction group started right away was naloxone distribution, and looking at how we could increase distribution of naloxone in the community. And initially looking at, you know, a delivery system, and there was posters put out and calls put out saying you could call this number and get a naloxone kit delivered from 9 a.m. till midnight every day of the week, right? And there was very little uptake when we started that program. There was 20 naloxone kits put out with that distribution, and really highlighting that, one, not everybody has a phone or access to the social media to see the posters, or is accessing support where they can get that information. And so one thing that was put into place from the harm reduction group was increasing the number of places that were distributing naloxone and doing community distribution. So the number of partners on that program has grown quite a bit, including, now being distributed through the Lighthouse and the STC Health Center, which is really important. And then AIDS Saskatoon has implemented a team of naloxone distributors that are looking at opportunistic distribution. So they fill their bags full of naloxone kits and they go and walk around the community. And so in 1 month, we've distributed 193 naloxone kits, just with 3 people walking around the community saying, would you like a naloxone kit, to the people who are outside in the alleys and in the parks and in the neighborhood who are using and need access to these resources more than anybody. Another good example of the collaboration is what we've been able to do with housing. And the housing piece, there's been lots of really big wins, and there's lots of still things that are still really frustrating in housing. And we identified right away that self-isolation was going to be really difficult. And we knew that if the virus hit the homeless population, it was going to spread really quickly, and that there wasn't going to be much we could do to stop it. And so how could we put people in a situation where they had the resources to self-isolate? And initially that looked like a fantastic multi-hotel structure where we could funnel people through and keep them, had a self-isolation hotel, a hotel for people who were COVID positive, and a hotel for people that needed to look at long-term housing, and that could be housed at a hotel temporarily while we looked at that. What ended up happening, which has still been a big win, is we do have a hotel for people who are COVID positive and people who need to self-isolate. And there is support staff there. One of the questions was around how do we get people to stay there and not take off once they, are staying there. And it turns out that the answers were really simple. Cigarettes. We started supplying cigarettes. We distributed new using equipment to the people who wanted to access it. We distributed naloxone kits to the people that were accessing those supplies. There was a MAP program, so a managed alcohol program, implemented in the hotel structure. So all of these things that we have fought for years to get implemented in community outside of COVID, we got implemented in a matter of hours here. And which goes to show you that a lot of these initiatives that we've been fighting and advocating for years around, inhalation supply distribution and naloxone kit community distribution and MAP programs and all of these things aren't that hard to implement if we just have the push and the drive to do it, and all those barriers that are put in place are taken down. The province initially announced that there would be 350 housing units in Saskatoon that would be available for homeless populations. What that turned into was 10. Now we've been able to show some great things with those 10 units, and we have, a case management team that's working with them and looking at long-term housing solutions. And we broke down a lot of barriers and have the, Saskatoon Housing Corporation and Saskatchewan Housing Corporation and the Saskatoon Housing Authority at a table looking at different ways of doing things in partnership. But those 350 units would have been really useful if we could have just gotten them. And so something that we've noticed from this, from how the collaboration has worked and how well it has worked, is it is really a frontline community agency and community support driven initiative. And we are still running into barriers once we go into those higher levels of systems. But because we decided to all work together and we're pushing it together, we've been able to implement these things without that support. And that's really important to see, is that we can, we have the power to do it if we can still do it. And I think there's some really good learnings we can take from this, post-COVID, into how we should be working together and how programs should be designed. The idea of people being too hard to house or too hard to serve or too difficult, and venturing into topics like ban lists, we've been fighting against those things for years. And, one of the, like you were saying, the meet people where they're at, well, programs aren't designed that way. They're designed to meet people where it's most convenient for the agency at that time and the funding body. And So when we talk about true harm reduction based programming, we're seeing those initiatives implemented no matter who you are, what you're going through, if you're using, what your mental health crisis is, any of those things, you can access these services. And that's the way it should be. And everybody should have the right to access services without judgment and without difficulty. And one of the things that we really need to take into our post-COVID planning and things that should be looked at is how are our programs designed to meet the needs of the people who truly need to access them, and get rid of these terms like hard to serve and hard to work with and hard to engage. People are only hard to engage because your program is not designed to engage them. And that is the reality of a lot of the systems and services that we have in our communities. And so as we are looking at what we've been able to do so quickly here, we really need to see that harm reduction based programming and applying those principles is really the way into designing services and systems that can look at those social determinants of health and really break down those barriers. Like you were saying, Barb, they don't have to be forever things, but harm reduction based policy is the way out of them.
No, I completely agree. And I'm just sort of thinking about program design and implementation. And, I mentioned sort of by youth, for youth before. It's critical that the people who are most impacted by policies and programs are involved in their design, implementation, and potential barriers to uptake are involved, meaningfully involved, right? So I'm not, typically as a researcher, what we used to do and hopefully are moving away from now is sort of, write up this big report and then I show it to you for half an hour and say, does this look all right? That's my consultation. And then out I go to implement this with policymakers. That approach is just it's not effective. And it leads to, like you were saying, it leads to people being asked to meet a program where the program's at rather than the other way around. And so ensuring that voices that represent people who use drugs, people without homes, people who are in all kinds of different situations are involved in that planning as stakeholders and are informed and doing the informing of that program so that it can be so that it will be effective and successful for the population that is being served. It's sort of, sometimes I'm like, well, yeah, that seems like the common sense way to do things. And it would make a little bit more sense to do things that way. We don't see this kind of approach where we sort of put the cart before the horse in other fields of healthcare in the same way that we do with substance use. We don't ask people with diabetes to go balance their insulin levels and then come back to get insulin later when they've successfully addressed that. But typically we ask for abstinence before admission to treatment programs. Typically we ask for basically for the problem to be solved before they engage our services. Well, that's again, putting the cart before the horse sort of thing, and it doesn't really make sense. So, but it did make sense in sort of a moralistic judgment world, which is basically a lot of the way that we have responded, particularly to substance use, is through this sort of pull up your bootstraps moralizing frame, which is part of the historical legacy of working in substance use in a sense. And that is shifting, but I'm often reminded of Deborah Small speaking at Harm Reduction 2017 in Montreal, and basically saying, right now we're reducing the harms of prohibition. What we need to do is reduce the harms of substance use. And so by and large, yes, major policy changes are required. And part of that change too is going to come through things like safe supply programs and ensuring that that people are able to be at home, right? As Kayla was saying, like if folks are asked to self-isolate and to be staying in one place, you need to ensure that all their needs are met in order to do so, right? So food, shelter, and in many cases, substances to ensure, as you were saying, cigarettes were the thing that helped people stay put. Great. And why not, So it's maybe counterintuitive to the war on drugs logic that we've all, or many of us grew up with, myself included, but it shows better health outcomes, it costs far less money, and it brings the humanity back into human services, frankly. So I think that's really important. One program, I just saw a question go by that somebody was asking for sort of an example of a program or service in other cities. The city of Hamilton in Ontario started putting naloxone kits in with their AED machines. around the city. So if folks didn't have an naloxone kit on them, the idea being that you could access an naloxone kit in most public spaces. And ideas like that, where, hey, we have some infrastructure set up for AED machines. It's not as terribly confusing to administer naloxone as sometimes the press and other agencies make it seem. It's really quite basic if you can, and particularly if you have nasal naloxone. You really don't even need training to use it. It's an easy to implement kind of support that just goes a long way to saying, I mean, fundamentally, we care, as a society, we care about you. We value you as a human being, and your dignity matters. You matter. And the Manitoba Harm Reduction Network had a great campaign. I love someone who uses drugs, was the slogan used there. And we all do. Substance use is not something that we're all sort of separated from. It's a topic that touches most of our lives. I think that's why folks are concerned and here, and why there's been such a response to this conversation today as well. I don't know anyone who isn't in some way impacted by substance use and our responses to substance use. So what we're going to do around that is try, and I think what we've got to try and do is sort of get rid of these judgmental ideas of this war on drugs attitude and start addressing, okay, what do people need, and what are they saying they need, and how do we ensure those supports are accessible and in place when needed. So a bit of a different shift, and really there was a question we received beforehand, sort of how do you talk to people who are very judgmental in a sense, or how do you tell them about the benefits of harm reduction? And for me, Stacey Swampy is a member of our community who comes in and speaks in my classroom sometimes, and I'm just going to basically take his breakdown and share it here. But, he always says, instead of seeing people as good or bad, bad people use drugs kind of approach, you need to see folks as healthy and hurting. That this is a continuum of wellness in a sense. This isn't an either or position. And if we can understand that somebody's hurting and expressing that hurt through behaviors that we might see as self-destructive in some way, or might be characterized in that way, that if we can see people as hurting, it's a lot easier to be empathetic and to speak with people and to retain that humanity. There's no bad people in the world in that sense. There's many contexts that many folks are surviving through, and understanding that, at the end of the day, meeting people where they're at means that whatever values I might bring to the table, personally, based on my experience, may not be the same values someone else is bringing to the table. And we need to be open to that conversation, and open to working in situations that may not be aligned with the rhetoric we grew up with. And that's okay. That's how change happens. And I encourage people to be uncomfortable a little bit in this conversation, especially if it's new to you. My comfort is not as important as someone else's health and well-being. And so, I need to hear what are they saying is most important for health and well-being, and full participation as a member of our society. So, this siphoning off, that siloing that we see in agencies, I think we tend to do that with people and with social groups as well. And ensuring that we're not siloing and not siphoning off is really important. So that connection piece again.
Well, and as we're, if you look at that mind shift around, how we're approaching people and how we're seeing people at a program design level, that means that we need to be designing programs that aren't based on short-term outcomes. We have systems full of programs that are based on achieving these outcomes in, a matter of a few weeks or a few months. But we don't see long-term sustainable change from those things. And what we see is a lot of people being pushed out of those programs and out of those services because they're not getting fixed fast enough for that system. And so when we look at ways of designing programs and policies, and, as people are entering into this field or designing programs or writing policy, those things need to be kept in mind, is that when we look at working with human beings and treating people as people, we need to understand that change is not a straight line from A to B, and that we can't fix everybody's problems in 3 months. And really, we shouldn't be looking at fixing people anyway. We should be looking at reducing and making their lives easier for today. But it should never be anybody's job to fix anything. And we're not here to fix people. We're here to make sure that for today and right at this moment that they have, at the very least, all of their basic needs met. And, one of the questions that was asked about, that was sent to us was about barriers to finding suitable homes. And as you're talking about the way people are viewed, the housing system is a great example of this. Housing systems are set up to look for ideal candidates, and which means that we often exclude huge amounts of the population who are not, rent ready and don't, fit this mold of what we think, who should be accessing programs. And then in order to access those programs, they have to change all of these things before they can even do that. Housing should be a human right, and housing is harm reduction. And, the foundation of what Housing First was meant to be was that if we house people first, then, over time we could work on everything else. But what, we've seen with, various Housing First programs is that it turned into housing the people that were easiest to house in that group of people. And it still excluded a whole bunch of things. And so the biggest barrier to people accessing safe and secure housing is that people just don't want to house them. They're harder to work with. They're not, if they're not staying sober, if there is gang involvement, if there is violence in the home, all of those things make them undesirable to house. And it means that there's a lot more work that needs to be put in to do so. And so we just design programs that exclude that whole population. I think that there was a couple of questions over here. There's one specifically about people who are in incarceration. And it's definitely, incarceration is not my wheelhouse at all. There's many people in our community that know far more about incarceration than I do. But one of the things that we saw right at the beginning of COVID was people who were close to being released or could apply for earlier release doing so and being sent out into the community with no resources. So we had people showing up. We had a community service hub that was set up right off the hop where people could get help with housing and income assistance and some of those basic financial needs. And we had people who were sent from Regina Correctional. They made it to Saskatoon and then were just dropped off here. And we saw this kind of mass exodus out of incarceration, but into nothing. And people couldn't get back to their communities. They couldn't get back to where they were going. There was one guy that presented at the community service hub who hadn't eaten in days because he was released with nothing and no access to resources. Nothing was open. And he was dropped off here and didn't know what to do. And so, as far as policies and procedures within those facilities and what they've done around COVID is really not something I can speak more so to. And I don't know if you have that information, Barb, but no. I have seen the implications of what happens when you just take this approach that we'll just get rid of the ones that we can, and the community is left there to pick them up. And, as I'm talking about this collaboration and all the things that we have done that with very little funding. There isn't huge streams of funding coming into a lot of the work that we're doing. There has been COVID response funds that have been put together. The interagency response has funded most things through a fund that's being managed by the United Way and the Saskatoon Foundation. And so they rolled some funds into that, and there's been community support for that. And we've had some dollars rolled into some of these programs, but we have done things and been able to work around things with really what is a small amount of money. When we look at, the cost associated with operationalizing some of these programs that have been closed and what is needed to return back to some sort of sense of normalcy in our community. Things like PPE and the cost of what's going to be associated with those. Nobody's offering up frontline agencies and organizations the money for that. When the Ministry of Social Services made their, announcement, I think it was on March 31st, around their support for homeless populations, $171,000 was what they released to shelters across Saskatchewan to offset costs associated with COVID. That doesn't even fund one shelter a few months worth of PPE. And so, we really need to look at, we want things to open, we want things to be done, but we don't have the financial support to do so. And so, the average cost for an agency for PPE to return to services has been calculated at about $25,000 a month. So without the resources to do that, so when we talk about what can people in the community do, what can we be asking for, what can we be pushing for, it's really, that support from those larger systems financially so that we can, run these programs and implement these things in our community.
100%. And I think just to add on the prison industrial complex question, I'm very biased in the sense that I support full abolition of the prison industrial complex. But so I put that out there. Just I am biased, but I think the releases certainly show us that perhaps prison was not the place that folks needed to be to begin with to address the issues that they were facing. The conditions within our correctional facilities are massively overcrowded and underfunded, as is the case in so many places, such that physical distancing of 6 feet is not really possible or available within certain institutions. And I know they're managing their overcapacity system as best they can in a sense, but I think it really begs the deeper question of remanding people, of keeping them in custody, and of what function we're expecting our prison system to serve here. Certainly it can't be rehabilitation if there's no programming available, everything's maxed out and whatever. It's a holding space. It's not providing the opportunities for rehabilitation that many Canadians think is, many people in our country sort of believe that that's what's happening in these facilities, and that frankly is not what's happening in these facilities. So when we see, the ability to massively release people, my question is, well, why wasn't this happening beforehand? Why were we institutionalizing people to begin with? Maybe our approach to the criminal justice system is something that we need to look at much more closely and with more rigor, and what our policies and procedures are going to be around remand or not, and so on and so forth. So I think it again points to this bigger question. When COVID sort of pressurized all our systems, a lot of places where we saw these little bursts come out were places that were problematic prior to COVID-19, that did not have the stability and adequate funding prior to COVID-19. And so COVID just added, but maybe the gift of COVID-19 is that, yes, the general population is seeing this. We're seeing the impacts of social determinants of health in almost immediately within 30 days, rather than, from a research chair 20 years later sort of thing, to see those impacts. So it's sort of made these disparities more visible to those who may not have seen them before or may not have been aware of them before. So in many ways, I think it's highlighting these issues, these ongoing issues that have been with us for a very long time. And now people are asking, well, why can't we respond during COVID-19? And it's because we were struggling to respond prior to COVID-19 because our priorities have not been in supporting people basically for a very long time, and we need to change that priority. COVID makes that very apparent. It's been apparent for quite some time. So. So yeah, sorry. Thank you for letting me just add to the prison question, and we are seeing things like needle exchange programs in facilities now, and that's a good thing. We need to keep going with that, absolutely. Trying to deinstitutionalize institutions as much as we possibly can, I think will be to everyone's benefit in the long run.
Mm-hmm. So. And something that ties into that and other things as we talk about substance use that we haven't touched on is safe supply. And that, there's been some safe supply initiatives rolled out across the country in different pockets, and showing that, the people's lives change when they have access to safe substances. And when we look at our drug trade and how things are brought in, COVID has really highlighted how substances move through our provinces, how they move through our cities, and how they're brought into our country. And when you don't have access to the same substances that you are accustomed to using, then you're more likely to be in a situation where you're going to face overdose because you're using substances in a way that you are not used to using them. And, you know, for so many of us that work in a harm reduction field, the idea of safe supply just seems so simple. You know, if people are going to use, why can we not support them to do so in a safe way? And why can we not make sure that they stay alive another day to continue to have the opportunity to make a different choice? And a lot of the times when we, you know, talk about people who are using substances, they are often seen as often like almost like expendable by society, right? You know, whether they live or die, it doesn't really matter. Well, it really does. Like, these are people's lives that we're talking about, and that should not be people dying as a way of proving that it was wrong that they were using substances in the first place. Should not be the standard in our country. And so something that has been you know, implemented really quickly in some places across the country is this idea of safe supply. And if we prescribed their substances and if they had access to them, then the implications on things like crime, healthcare outcomes, and, you know, the person's well-being are huge.
And folks can look into that too with BCCSU released provincial guidelines for British Columbia for prescribers to help meet the needs of people who use drugs. And then that document has also been scaled up by CRISM on a national scale. And it's basically a resource for care providers who are prescribers to guide them in how to best offer that support to their patients when their patients are seeking it. You know, and I am a supporter of the safe supply call and movement. I think folks need to understand what safe supply is and means. And a great resource for that was put out by the Canadian Association of People Who Use Drugs just last year, I think it was. And it's basically what is safe supply, and understanding that it's different from a substitution therapy program, understanding that it's not, the aim here is not to taper use and get people abstinent sort of thing, that it's about providing people with the substance, their choice of substance of use, and trying to ensure that they're not getting a poison supply, which has been another impact of shutting down a lot of the border trade and things like that. We've seen what we call the illicit supply has further degraded, basically, and so folks aren't able to secure a supply in that illicit market. Again, begging the question of whether we should have been pushing people to an illicit market to begin with. But the point being that medical practitioners can help in this situation now through their prescribing practices, and of course understanding that there was a lot of critique put on the medical profession during the opioid epidemic that we've been experiencing for overprescribing opioids. And this is, you know, we've heard about this in the States and Purdue Pharma and so on. And so I know some providers are very cautious and they're very concerned because they were met with this critique. Meeting the medical needs of your patients is not the wrong thing. And there's practitioners in British Columbia who are willing to offer their expertise and understanding and help other practitioners learn to do this in a what they would say is a medically appropriate way. Dr. Christy Sutherland being one example of many, and encouraging care providers to advocate for their patients in the way they have been doing, but to ensure that that's followed with policy change as well whenever possible, so that people shouldn't be putting their medical licenses at risk to meet the needs of their patients, and we need to ensure that our whole system is supporting the access and provision of supply for people who use drugs.
Mm-hmm. There was a question about to change policy in a large organization, how do you go about that as a frontline worker? And that's a question I've gotten a lot over the years. And I'll often preface it by saying, I don't work in a large system. I work for a nonprofit. I always have. And I work in a system where, my clearance is going to my boss and saying, can I do this? Right? Like there's no hierarchy of anything that I need to, go through. And I am very fortunate to work with like-minded people. And so for people that work in systems, and I talk about this when I talk to child protection workers a lot, is that you have control over how you operate within that system first and foremost. And the root of so much of what harm reduction has to do with. It's really about building meaningful and respectful relationships with the people that you are supporting. And you always have control over that as a frontline worker. You have control over how you approach things and how you work with people. Something that, people who don't necessarily believe in harm reduction or see the value of harm reduction that always is really important is breaking it down to effectiveness, right? So if you can show that you as a worker operating in this way have been able to achieve these outcomes and show these things, that can go a really long way. Showing the value, like if you're in a position where you can actually show the dollar and cents that you're saving by doing these things, that's really important. And beyond that, it's really important to stay educated. And there's lots of ways that you can support harm reduction agencies and initiatives and groups without having to be working for them. And, that advocacy piece is always important. Having those conversations with your government is also really, really important. And that, as an individual, you can jump on the cause and you can do these things and advocate in a way that maybe happens outside of your job. But I don't envy people that work in those large systems who see the benefit, but don't know how to see the change. And, it's about keeping those conversations going and bringing the evidence-based things. There is lots of evidence that supports harm reduction initiatives and the efficacy of them and the financial cost savings that come along with it. And so, keeping yourself educated and then taking those things to the people around you. And, you can affect change with your coworkers and your immediate team members, and talking about the environment that you're creating for people that are accessing services also goes a long way. Because even if you, may not ever be able to change the larger system in a significant way, maybe you can change the program that you're working for and how they're working with the people that need support the most.
100%. And yes, Shay, just seeing your comment online, absolutely. Pandemic prescribing may end at the end of the pandemic, whenever that comes. And again, this is, I think, COVID showing us there is this opportunity here. There is a better pathway, in a sense, than what we're doing. So thank you for bringing that up, and for the good work that you're all doing with stimulus and other activities. Canadian Drug Policy Coalition also has some excellent resources. Speaking of that evidence base, they began putting together a lot of COVID-19 specific resources right at the start of things. And so there's a large collection on their website for access for those who are looking for sort of more detail or different opportunities to engage in that. I also highly recommend the Canadian Drug Policy Coalition as an advocacy group and body that you could be involved with, that many people I think should be involved with, keeping that current evidence, policy changes and all that at the forefront of our thinking in terms of implementing institutionalized change. Yes, an evidence base makes a heck of a difference in terms of being able to argue effectively for larger systemic changes. Understanding that change takes time in larger organizations, but also that the more folks you have, in a sense, if you can get a few champions within an organization who are saying, hey, this works and this is effective, the more voices you can add to that, the more pressure within the system to change. And hopefully that moves things forward in a positive way.
Yeah. So we've just had a question pop up around safe consumption sites and injection services after seeing an increase in IV-related infections in hospital due to lack of knowledge or having the equipment to inject in a safer way. So part of the just in general with injection, having new supplies is really important, and having those supplies accessible, but also having things like access to clean water. We really take that for granted. And there is a big difference in the substances that people are going to be injecting if they have clean water versus if they're using puddle water or liquids that they're finding around on the street, right? And so that will definitely increase the risks of infections and issues. Education around injection is really important. And, AIDS Saskatoon ran a needle exchange program for a long time. And one of the things that we, as staff often would get asked about from people was how to inject, and having those conversations and saying to somebody and almost creating that normalcy in that conversation around, like, how are your veins? What do they look like? Have you, maybe you need to be doing this. Have you tried smoking, right? Having those conversations in a really meaningful way. And if you're in the hospital and seeing these patients, you have an opportunity to do that education around what that looks like and finding out, kind of where their barriers to that safe injection is. I happen to be sitting in a room where on the other side of my wall is a safe consumption site that is currently, we're planning to open just as COVID hit. Like, that was the initial plan, was that we would be opening, and then COVID hit. And the provincial budget was announced the week after COVID hit the province. And we unfortunately did not get our provincial funding for a safe consumption site. That does not mean that we are not planning on opening our safe consumption site in one way or another. And part of the struggle that many organizations are facing right now is, as the phase out or phase in plans of reopening have come into play, they have not factored in community organizations at all. And so we're kind of going by the seat of our pants, trying to figure out, where do we fit in these phases and when we can safely reopen services and stuff. And one of the conversations we're having is the safe consumption site and opening the doors to that part of our building. For anybody that doesn't know where AIDS Saskatoon is, we're on 20th Street between Avenue O and Avenue P. And if you walk through the alley behind our building at any given point, you will see people injecting drugs. It is something that is not a hidden phenomenon in our community. It is something that is happening outside of our building at any given point all the time. We have discarded needles throughout the neighborhood, and that is something that our communities have been facing for years, right? Is that there's improperly discarded needles in places where they shouldn't be. And, we have needle patrollers that go out and safety things that put in place, but really what we are needing and what we're seeing and what the community is begging for, like when we moved into this building in November, people have been asking since we got into this location, when can they use those services? When can they have access to those supports? When can they, use their substances in a safer way and do it in a supportive environment? And so, as we go forward and look at implementing injection services and substance use services in our building, we need to look at how we're going to fund these services. And we as an agency are very driven to figure out a way to do that, which may rely heavily on community support to do so. We also, we're talking about injection. We have the second safer smoking room in Canada that will be implemented with these services as well, and recognizing that safer smoking and access to safer smoking is a really good alternative to people who are using injection drugs, or people who are newly introduced to substances and have been introduced to smoking substances. If we can keep them smoking, then their health outcomes potentially could be, not potentially, they will be better in the long run, and their risk of contracting HIV or hepatitis C and dealing with the different infections that come along with injection are gone. So we have this wonderful building sitting in our city that is ready for use. And now we just really have to try and find the resources so that we can open those doors and get it up and running.
Another resource I'll sort of throw into this conversation is the Toward the Heart initiative it's a harm reduction initiative from the province of British Columbia. But if you just Google on Facebook Toward the Heart, there's a lot of information, instructional videos, and other good resources for folks to practice safer injection use.
Yeah. I know we, for a long time, had little cards that had a man on it that would show like all the places that were safe to inject and where it wasn't, but something about people who have been injecting drugs for a long time. And we see this in our alley all the time, is we have a lot of people who are doing what's called jugging. And so they are injecting in their jugular, often because that's the vein that's left for them. And so, there's a lot of safety things and education that needs to come through professionals and people who are coming into, interactions with people who are using substances, and that, the education around how to use safely, proper vein care and things like that. But with COVID, even something as simple as access to clean water, like we just don't have those resources in the same way. I think that was the last of our questions, Barb.
I think so. That was very impressive.
Yeah.
Okay. Oh, it's, I guess again, what, going back to that sort of what people can do question, keep having the conversation is really, it is changing. It has changed. I was saying when we jumped online this morning that when I first taught the Studies in Addictions course, it was a radical notion. Harm reduction was just so radical, so out there. It was quite the conversation, and I was still explaining the harms of the war on drugs to many of the learners in that class. And last year, my students were like, "We want to write applications for safe consumption," and so there has been a wave of change. People are recognizing the important impacts that harm reduction has, and if we keep talking about that and keep getting loud about it, it will change over time. It really will. So. And yes, Chasing the Scream, the first and last days of the war on drugs. Excellent, excellent book. Dr. Gabor Mate's Realm of the Hungry Ghost, published way back 2009, I think it was now, talking about the roots, trauma and all those other factors that come into it, along with personal narrative. There's a lot of good resources out there that can help folks have a fuller understanding of substance use and of harm reduction more broadly. Harm Reduction International is another organization that I think folks should maybe be aware of, or they have a lot of good resources talking about harm reduction on a global scale, and where North America fits in that and where Canada fits in that. So another good resource.
Is there any last comments from either of you?
Just thank you very much for taking the time to listen to us. And those were fantastic questions. What a fantastic conversation. And so fantastic to see so many people really engaged in this topic, and really interested in learning more and advocating for more.
Yeah, thank you all so much for being here, and yeah, for the very thoughtful questions, and to the Division of Social Accountability for hosting the conversation, and to all the experts in there in watching and throwing and putting their information in. Thank you, Beryl. It's good to see your name, and James, and so many others, and Elizabeth. And I just feel like I just need to read the attendee list and thank them all for being here. So thank you all so much for the time today.
Yeah, thank you both. This was really excellent, and for sharing your insights and experiences, and for everybody, like you said, sharing such insightful questions. I did want to plug next week, the same time, we'll be having another conversation around community responses to food insecurity during the pandemic in Saskatoon. So again, we'll be talking with some of the people and agencies that are also part of the Saskatoon interagency response that Kayla was referring to. So if you're able to, please do join us for that conversation. If you do miss it, we will be posting recordings both of this and next week's sessions, as well as our previous sessions on our website. So you can still tune in if you're not able to join in person. But just want to thank you both again, and for everyone else for being here, and hope everyone be well. I'll talk to you soon.
Thank you. Take care all.